What I'm about to tell you could be the most important thing you hear this year about the blood pressure medication you take every single morning. Because if you're a senior taking Amlodipine, Losartan, or Lisinopril, there is a piece of critical information that most people over 60 never receive, and it has nothing to do with remembering your dose or checking your numbers. It has to do with what happens inside your body over months and years on these drugs when nobody is watching closely enough. And that is the part that keeps me up at night. Because the danger is not always a dramatic side effect that hits you in week one. Sometimes the danger is the slow, quiet shift that everyone, including you, writes off as just getting older. Before we go any further, please subscribe to this channel so you never miss essential health information that could protect you or someone you love. Now, if you're over 60 and you've been prescribed Amlodipine, Losartan, or Lisinopril, there are 12 things you absolutely need to understand. Not tomorrow, not at your next appointment, right now. Because the gap between what you were told at the pharmacy counter and what you actually need to know to stay safe on these medications is wider than most people ever realize. And by the end of this, you are going to understand which warning signs demand immediate action, which ones are deceptively harmless sounding, which common daily habits could be quietly undermining your medication, or worse, turning it against you, and why the most dangerous moment in blood pressure treatment is not the day you start the pill. It's the month you stop paying attention to what it's doing. Let me begin with a woman I'll call Margaret because her story is the reason this conversation cannot wait. Margaret was 74. Sharp mind, strong will, never missed church or a medication dose in her life. She had been on Amlodipine for about a year. Blood pressure numbers looked wonderful. Her family was relieved. Her chart looked clean. But Margaret had started doing something that nobody noticed. She had stopped going on her evening walks, not because her knees hurt, not because she was tired, because every evening her ankles swelled so badly that her shoes felt like they were cutting into her skin. She was embarrassed. She thought she was gaining weight. She thought maybe her heart was giving out. She told no one. She just quietly stopped moving. And here is what terrifies me about Margaret's story. The medication was doing exactly what it was designed to do for her blood pressure. But because no one had clearly explained one very specific side effect of Amlodipine, Margaret made a series of silent decisions that were slowly destroying her mobility, her confidence, and her overall health. She didn't need a different diagnosis. She needed a complete explanation. And that brings us to number 12. The foundational truth that changes everything else you're about to hear. These three medications, Amlodipine, Losartan, and Lisinopril, are not three versions of the same pill. They are three fundamentally different drugs that work through three completely different mechanisms inside your body. Amlodipine is a calcium channel blocker. It relaxes the walls of your blood vessels by blocking calcium from entering muscle cells in those walls. Losartan is an angiotensin II receptor blocker, an ARB. It works by blocking a hormone that tightens blood vessels and increases blood pressure. Lisinopril is an ACE inhibitor. It blocks the enzyme that produces that same hormone in the first place. Same destination, completely different roads, and the road determines what you feel, what can go wrong, and what you need to watch for. If you don't understand which road your medication is taking, you will misinterpret every signal your body sends you. You will confuse a predictable side effect with a new disease. You will panic when you should be calm, and you will stay calm when you should be alarmed. And both of those mistakes can cost you dearly. The name on your bottle is not just a name. It is a map. And for the next few minutes, I am going to teach you how to read that map. Number 11 is the side effect that fools more seniors than almost any other. And Margaret lived it. Amlodipine causes peripheral edema, swelling in the ankles, feet, and lower legs, and it is one of the most common side effects of this drug, especially in older adults, especially at higher doses, and especially as time goes on. But here is the problem. Most people do not connect the swelling to the medication. They connect it to salt, to sitting too long, to aging, to their heart, to kidney problems, to weight gain, to a dozen other explanations that send them down a rabbit hole of worry and unnecessary testing. The swelling from amlodipine happens because the drug relaxes the small arteries but does not equally relax the veins. So blood flows down into the legs with less resistance, but it has a harder time getting back up. Fluid leaks out of the tiny blood vessels into the surrounding tissue. Gravity does the rest. That is why the swelling is often worst in the evening and better after a night of sleep with your legs elevated. Let me tell you about a man I'll call Henry. Henry was 79 and had been on amlodipine for about 4 months. He noticed his ankles getting puffy in the afternoon. Then his socks started leaving deep indentations. Then one day, his wife looked at his legs and said they looked like sausages and insisted something was seriously wrong. Henry went to the emergency room convinced he was in heart failure. They ran tests. His heart was fine. His kidneys were fine. It was the amlodipine. But here is the part that made me furious on Henry's behalf. He had been living with escalating anxiety for weeks. His wife had been terrified. They had spent an entire day in the emergency department. And all of it, every single minute of fear, could have been prevented by one clear sentence at the time the medication was prescribed. This drug commonly causes ankle swelling. It does not mean your heart is failing. But if it becomes severe or bothersome, we need to talk about it. That sentence was never said. And Henry is not unusual. He is typical. Now, does this mean amlodipine is a bad drug? Absolutely not. For many people, it works beautifully. But the swelling is not rare. It is common. And if you're taking amlodipine and your legs are swelling, you need to report it, not suffer through it, and certainly not assume the worst without talking to your clinician. Number 10 is the side effect that disguises itself as a dozen other problems. If you take lisinopril, listen to me very carefully. Lisinopril can cause a dry, persistent, hacking cough. And this cough is one of the most frequently missed medication side effects in all of medicine. Not because it is subtle. It is not subtle at all. It can be relentless. But because it often does not start immediately. Sometimes the cough begins days after starting the medication, sometimes weeks, and sometimes it creeps in months later, so slowly and so gradually that you never once think to connect it to the pill you've been taking without incident for a long time. The cough is dry, no mucus, no phlegm. It feels like a tickle that will not go away, like something is stuck at the back of your throat. It is often worse at night, which means it destroys sleep, which means it destroys energy, which means people start feeling run down and exhausted and blame their age when they should be questioning their prescription. Let me tell you about a woman I'll call Dorothy. Dorothy was 71 and had been on lisinopril for 5 months when the cough started. She thought it was allergies. She bought antihistamines. Then she thought it was acid reflux. She started sleeping propped up. Then she thought maybe it was the dry air in her home and bought a humidifier. She spent money, lost sleep, and grew more frustrated every week for nearly 3 months before someone finally asked her the right question. When exactly did this cough start, and were any medications changed around that time? The moment she heard the question, the connection was obvious, but she had never been told to watch for it, and so she suffered in silence, assuming the problem was her body rather than her medication. This is not a rare side effect. Studies suggest the ACE inhibitor cough affects a significant percentage of people who take these drugs. Some estimates put it as high as 1 in 5 patients, sometimes even higher in certain populations. So if you're coughing and you take lisinopril, do not spend months chasing other explanations before considering the most obvious one. Now, I need to pause here and tell you something that is far more serious than a cough, because this next part is not about discomfort. It is about danger. In rare cases, ACE inhibitors like lisinopril can cause angioedema. That is sudden, severe swelling of the lips, tongue, face, or throat. It can come on without warning. It can obstruct breathing, and it is a medical emergency. If you are taking Lisinopril and you notice swelling of your face, lips, tongue, or throat, or if you have any difficulty breathing or swallowing, you do not wait. You do not call your pharmacy. You do not monitor it overnight. You seek emergency care immediately. This is not common. But it is serious enough that every single person on an ACE inhibitor needs to know it exists, and many do not. A cough is a conversation with your clinician. Throat or tongue swelling is a conversation with an emergency room. The difference between those two responses could be the difference between discomfort and catastrophe. And if you do not know that distinction, you are not fully informed about your medication. Number 9 is the silent danger that hides in your kitchen. If you take Losartan or Lisinopril, your body may handle potassium differently than it did before you started the medication. Both of these drugs can cause potassium levels to rise. An elevated potassium, a condition called hyperkalemia, is not something that announces itself with a loud, unmistakable symptom. It whispers, muscle weakness, unusual fatigue, a strange tingling in your hands or feet, an irregular heartbeat, sometimes nothing at all until it becomes critical. And here is where the kitchen comes in. Many seniors, trying to do the right thing for their hearts, switch from regular table salt to a salt substitute. And most salt substitutes replace sodium with potassium chloride. So now you have a drug that raises potassium combined with a seasoning that adds even more potassium in a person whose kidneys may already be less efficient at clearing potassium because of age, because of the medication itself, or because of mild kidney changes nobody has caught yet. Let me tell you about a man I'll call Walter. Walter was 77, retired engineer, meticulous about his health. When his doctor told him to reduce sodium, Walter went home and replaced every salt shaker in his house with a potassium-based salt substitute. He used it generously, on salads, on eggs, on everything. He was also taking Losartan. He felt good about his choices. He was following the rules. Then he started feeling weak. His legs felt heavy. He noticed his heart skipping beats occasionally. He assumed it was stress or poor sleep. At his next blood work appointment, his potassium was dangerously high, not a little elevated. High enough that his physician's face changed the moment the result came in. Walter did everything right according to the information he had. The problem was the information he had was incomplete. Nobody had told him that his blood pressure medication and his salt substitute were working together to push his potassium into a dangerous range. And that combination is sitting in kitchens all across the country right now. If you take Losartan or Lisinopril, you need to read the label of every salt substitute, every electrolyte drink, every seasoning blend, and every supplement in your home. And you need to have a real conversation with your clinician about how often your potassium should be checked. This is not optional. This is not overcautious. This is basic medication safety that too many people learn about only after a frightening lab result. Number 8 is the one that catches people off guard during the most ordinary moments of life. All 3 of these medications, Amlodipine, Losartan, and Lisinopril, can cause dizziness. But what most people picture when they hear dizziness is a dramatic room-spinning episode. That is not usually what happens. What usually happens is quieter and in some ways more dangerous. You stand up from the couch and the world goes gray for a second. You get out of bed at 2 in the morning and your legs feel uncertain. You bend down to pick something up, and when you straighten, there is a moment, just a moment, where everything feels unsteady. In a 30-year-old, that moment passes and nothing happens. In a 75-year-old, that moment is the difference between a normal night and a broken hip. Let me tell you about a man I'll call Eugene. Eugene was 81. He lived alone and was fiercely independent. 3 days after his amlodipine dose was increased, he woke up at night to use the bathroom. He swung his legs out of bed, stood up, and immediately felt the floor shift beneath him. He grabbed the nightstand. It slid. He went down. He fractured his wrist and spent the next 6 weeks in a cast, unable to cook for himself, unable to drive, unable to do the things that made him feel like himself. When I asked him later whether anyone had told him to sit on the edge of the bed first, wait a few seconds, and then stand slowly, he looked at me like I had described a foreign concept. Nobody had said those words to him, and that omission, those 10 seconds of instruction that were never given, cost him 6 weeks of independence and months of rehabilitation. If you are a senior on any blood pressure medication, the way you get out of bed matters. The way you stand up from a chair matters. The speed at which you move from lying to standing matters, especially in the first few weeks of a new medication or a dosage change, and especially at night. This is not about being fragile. This is about being strategic. You are taking a drug that lowers the pressure pushing blood to your brain. When you stand up, gravity pulls blood downward. If the drug is doing its job aggressively and you stand too fast, your brain can momentarily lose adequate blood flow. That is the dizziness. That is the grayness. That is the moment you fall. Mild adjustment dizziness in the first few days may resolve, but persistent lightheadedness, near fainting, or repeated episodes of feeling unsteady are not things you should power through. They are things you report. Because there is a difference between your body adjusting and your medication being too strong for your current physiology, and only a clinician can tell the difference. Number 7 is one of the most common ways seniors accidentally sabotage their own blood pressure treatment, and it has nothing to do with the prescription itself. If you take Losartan or Lisinopril and you regularly use ibuprofen, naproxen, or other over-the-counter anti-inflammatory pain medications, you may be creating a dangerous interaction without realizing it. These pain relievers, known as NSAIDs, are everywhere. People take them for back pain, knee pain, arthritis, headaches, stiffness after gardening, soreness after a long day. They do not think of them as serious medications. They think of them as helpers, harmless, something from the drugstore shelf, not the pharmacy counter. But NSAIDs can reduce the effectiveness of Losartan and Lisinopril. They can counteract the blood pressure lowering effect. And more dangerously, when combined with these blood pressure drugs, especially if a diuretic or water pill is also in the mix, NSAIDs can reduce blood flow to the kidneys and increase the risk of acute kidney injury. This combination is sometimes called the triple whammy in medical literature. An ACE inhibitor, or ARB, plus a diuretic plus an NSAID. Each one seems reasonable on its own. Together, they can quietly devastate kidney function, particularly in an older adult who may already have mildly reduced kidney reserves. Let me tell you about a woman I'll call Estelle. Estelle was 76. She took Losartan for blood pressure and a low-dose water pill for mild fluid retention. She also took ibuprofen 3 or 4 times a week for arthritis in her hands and shoulders. Nobody had ever told her this was a problem. She mentioned the ibuprofen to no one because no one asked, and she didn't think of it as relevant. It was just something she picked up at the store. Then her lab work started to change. Her kidney numbers shifted. Her blood pressure became harder to control. Her clinician adjusted the Losartan dose, thinking the medication was losing effectiveness. Nobody questioned the ibuprofen until a very thorough review of everything Estelle was taking, including things she bought without a prescription. The moment the ibuprofen was identified and removed and a safer alternative was discussed, things started to stabilize. This is a conversation that should happen at the very first visit. It often does not. So I am telling you now, if you take Losartan or Lisinopril, especially alongside a diuretic, and you are using ibuprofen, naproxen, or any NSAID regularly, your clinician needs to know. Today, not at your next visit in 4 months. This interaction is too common and too dangerous to leave to chance. Number 6 is the danger that arrives on the days you feel the worst. If you are taking Losartan or Lisinopril and you develop a stomach bug, food poisoning, severe diarrhea, vomiting, high fever, or any illness that causes significant fluid loss, the rules change. Everything changes. On a normal day, your medication is calibrated for a body that is reasonably hydrated, reasonably stable, with kidneys that are processing a normal amount of fluid. On a sick day, that balance is gone. You are dehydrated, your blood volume drops, your kidneys are under stress, and now the medication that was perfectly appropriate yesterday is acting on a body that cannot handle it the same way. Blood pressure can plummet, dizziness can become severe, kidney function can deteriorate rapidly. And the person who has been diligently taking their pill every morning, no matter what, is the person most at risk because they keep taking a medication that a depleted body can no longer safely process at the usual dose. Let me tell you about a man I'll call Raymond. Raymond was 80. He lived by routine. Every morning at 7, he took his Losartan and his other medications without fail. 1 week, he caught a stomach virus. He could barely keep water down. He lost fluids for 2 straight days. But every morning, right on schedule, he took his Losartan. On day 3, he stood up from his recliner and collapsed. His wife found him on the floor, conscious but disoriented. In the emergency department, his blood pressure was dangerously low and his kidney function had dropped sharply. Raymond was not being reckless. He was being responsible, or so he thought. He believed the most important thing was never missing his medication. And nobody had ever told him that there are days when taking the medication as usual is more dangerous than skipping it. Every person on Losartan or Lisinopril needs a sick day plan. You need to know before you get sick what to do when you cannot keep fluids down. You need to know when to hold the medication and call for guidance. You need to know that blind adherence during dehydration is not dedication. It is risk. Ask your clinician now while you are healthy, what should I do with my blood pressure medication if I get sick and cannot stay hydrated? Write the answer down. Put it somewhere you can find it, because when you are vomiting at 2 in the morning, you will not remember a conversation from 6 months ago. You will reach for what is familiar, and what is familiar is the pill bottle. Have a plan. Number 5 is the mistake that intelligent, health-conscious people make because they trust numbers more than patterns. Blood pressure is not a fixed number. It is a living, breathing, constantly moving physiological measurement that changes with every heartbeat, every breath, every emotion, every meal, every conversation, and every trip to the bathroom. A single blood pressure reading is a photograph of one moment. It is not a diagnosis. It is not a verdict. It is not proof that your medication is working or failing. But people treat it that way. They check their blood pressure once, see a number they don't like, and spiral into panic. Or they see one perfect number and assume everything is fine forever. Both reactions are wrong, and both lead to dangerous decisions. Let me tell you about a man I'll call Clarence. Clarence was 69 and had just started Losartan. He bought a home blood pressure monitor, which is a wonderful thing to do. But Clarence checked his pressure 8 to 10 times a day. Every time he felt nervous, he checked. Every time the number was high, he checked again immediately. Every time it was still high, he became more anxious, which made the number go higher, which made him check again. Within 2 weeks, Clarence was convinced his medication was useless. He called demanding a stronger drug. He was considering stopping Losartan entirely and trying something else. When we reviewed his numbers carefully, a different story emerged. His morning readings, taken calmly after sitting quietly for 5 minutes, were actually reasonable. The high readings were almost always taken during moments of stress, immediately after physical activity, or right after a previous high reading had frightened him. Clarence did not have a medication problem. He had a measurement problem. And his anxiety about the numbers was producing the very numbers that fueled his anxiety. If you check your blood pressure at home, take it at consistent times. Sit quietly for 5 minutes first. Do not check it immediately after exercise, eating, an argument, or a stressful phone call. Take 2 or 3 readings, a minute apart, and note the average. Look at trends over weeks, not individual snapshots. And do not, under any circumstances, change your medication dose based on a single reading without talking to your clinician. Medications like Amlodipine, Losartan, and Lisinopril are designed to work over time.